Marcia Day Childress from the Center for Biomedical Ethics and Humanities here at the School of Medicine, and we're delighted to bring you the Medical Center Hour weekly through much of the academic year. This is actually the first program of the 2014-2015 year. It's actually the beginning of our 43rd season of continuous production. This particular hour at midday on Wednesdays has long been reserved for some of the medical schools and the university's richest discussions. And so we're so pleased today to begin another year-long series of conversations with you. I'd like to just say at the start of the year that we're very grateful for the School of Medicine's support all of these decades, and especially for funding that comes through some endowed lectureships, including through the John F. Anderson Memorial Lectureship Endowment, a gift that was made in 1955 by medical alumnus Dr. John Anderson. This gift truly keeps on giving nearly 60 years later and still counting. But also we're grateful for you, our audience, for your presence, and looking ahead for your lively participation in the 20 programs that we'll be bringing you this year. We have a great lineup of speakers and subjects, but really at heart, I'd like you to consider this your forum. Your voices and your views are essential to the success of this enterprise. So we count on seeing you here and on hearing from you each week. If there are weeks you can't be here, please take a note in your handout of the YouTube address, and within a week, the video recording of the program is posted to YouTube, and you can watch it there. This opening program is entitled Healing in Medicine, Lessons from Clinicians and Patients. Medical students and young physicians, and some older ones too, are always eager for guidance about how best to apply their knowledge and skills in patient care. In practice, and especially in primary care, who might be the best role models for young trainees? What skills and traits do the best clinicians use to create healing relationships with their patients? And a deeper question, how do clinicians become healers? That is, practitioners effective in making their relationship with the patient itself have active therapeutic potential. Curious about these questions, Professor Larry Churchill and colleagues at Vanderbilt University School of Medicine did extensive interviews with both clinicians and patients about what actually makes for a therapeutic encounter. The research team has published 2 books based on their studies, Healers, Extraordinary Clinicians at Work, and What Patients Teach, both published by Oxford University Press. In this Medical Center Hour, Professor Churchill will discuss his study's findings and talk also about the implications of the research for medical ethics, for medical education, and for truly patient-centered practices. Larry Churchill is the Anne Geddes Stallman Professor of Medical Ethics in the Center for Biomedical Ethics and Society at Vanderbilt University. He also holds appointments in the departments of medicine, philosophy, and religion. Partnering with us on this program is the Medical School's Generalist Scholars Program. And Stephanie Hunt, who's seated on Larry's right, is a second-year medical student and one of our Generalist Scholars from the class of 2017. She will briefly respond to Professor Churchill before we turn to you for your comments and questions at the close of the hour. You'll find brief bio sketches of both speakers in your handout. And I'll also let you know, as the handout does too, that neither one of them disclosed any financial conflict of interest in relation to this program. Our other institutional partner today is the University-wide Institute for Practical Ethics in Public Life. And this Medical Center Hour is also part of UVA's observance of Primary Care Week. So welcome Larry Churchill and Stephanie Hunt, and I think we're in for an interesting and thought-provoking hour.
Thank you. It's working. You hear me in the back row? Okay. Thank you. Thank you for that generous introduction, Marcia. I'm really glad to be back at the University of Kenya, which I haven't been for some time, because it is well recognized nationally and internationally as one of the premier units for bioethics and healthcare ethics, and just a wonderful group of people. So I'm always pleased to be in Charlottesville. I'm going to try to talk for about 30 minutes. And one of the reasons for that is selfish, because I know what I'm going to say, but I don't have any idea what you might say. And lectures for me are always an excuse to open a conversation. So that's the learning for me. So I hope, I'm really interested in what Stephanie has to say, but I'm also very interested in what you may be able to tell me and the rest of us about your own experiences in this realm. So one of the questions you might be asking is, why should anybody study this area? And these are just two of the kind of rationales that informed our work. Rachel Naomi Raymond is a person who's really given her life to this question about how do you really care for people who are suffering. And Ed Pellegrino, who I think of as sort of the grandfather of American medical ethics, the late, great Ed Pellegrino, one of the important things he said was this, and I didn't think sufficient attention had ever been paid to this, that the center of medical ethics really is the healing relationship. Other reasons have to do with this idea that everybody talks about healing, but nobody seems to have any real, clear facts about what happens. So if you were to Google healing, you would find music, pets, friendships, sexuality, all kinds of things which people contribute, they think it contributes to healing, but the evidence for that is sort of lacking. So one of the things we thought is we need to try to demystify this notion and bring it down to earth and talk about it in a practical way. But also, if this is something that ought to be taught in health science schools, then what are we teaching? How would we know how to go about introducing students to this and judging proficiency? So the old saying, you know, if you don't know where you're going, any road will get you there, applies here. And that our current educational experiences for students in this area can be somewhat sporadic. They're sometimes just a matter of luck. So just to show you that we just didn't make all this up, this is something that all of us are familiar with, although it usually goes under a different label. This is one of my very bright medical students, Eve Henry, who did an awful lot of background research on this in terms of trying to model it. And this is what she came up with. Clinician suggestions, traits, and actions, the patient's faith in the clinician, a lot of cultural factors, create expectancy to be helped, which create chemical changes in the brain resulting in systemic changes. This is a highly simplified model, but I think you get the idea. We like to call this the healing response because that's kind of the larger outcome. If you were a medical anthropologist, you might talk about this as the meaning response, like Daniel Moorman does. Or if you were a clinical investigator, you might talk about this as the placebo response, against which new drugs are going to be tested. But it's essentially the same phenomenon, and it's a phenomenon that's well known and recognized, I think, by all of us. So here's our working definition. What one does in qualitative research is help, let the participants help you define the subject that you're investigating. So this is what we did. We started out with some ideas about what this would mean, but then we began by asking, how do you define healing? And our interviewees almost all said something like this. It's like fixing, but more. Or sometimes they would say it's kind of like fixing or curing, but it really has to do with something bigger, restoring people to a sense of wholeness in their lives. And it always involves some kind of relationship. I love the surgeon who said, healing results from doing relationships well. So I want to talk about two studies briefly. The first study is a study of clinicians in which we did 50 face-to-face interviews with clinicians who were judged by their peers to be extraordinarily good in this domain of practice. So we did a sampling by just asking people we knew, who's really good at this? Who's just loved by their patients? And then when names began to crop up again and again as we expanded the circle of conversations, we would say, this is the person we want to interview. Okay, so we found our interviewees in this way. We interviewed 40 MDs, and you can see they spanned a very broad range of specialties. We did 10 complementary and alternative medicine practitioners because our thinking was, well, there may not be a lot of science to what they do, but let's find out if their interpersonal interactions are any different from the MDs. We found that they weren't any different, really. They all did pretty much the same thing. It was a Southeast sample, although the clinicians in the sample were educated actually all over the country. And you see the breakdown in terms of academic and community. This is what's called in the social sciences a purposive sample, not a random sample in which you would be hit or miss. So you think somebody's really good at something and they tell you a lot about it and you hone in on them. Also, it was very hard to figure out how you would do a random sampling for a subject like this. And this is the interview guide, very straightforward. How do you go about establishing and developing relationships with your patients? And we would usually embellish that by saying a relationship that works well, a relationship that has some therapeutic qualities to it. And we said, we don't want to know about your theories. We want to know what you do. Tell us what you do. What are the actions you take? What are the things that you say? And we would hypothetically say, let's imagine you're seeing a patient for the very first time. What are the things that you want to be sure happen in that interaction? Okay? And these are the 8 skills that we came up with. Now they're all in the imperative mode because that's the way they came to us. The responses would go something like this. If you want that patient to work well with you, you have to do this. You have to take time and listen, okay? Now, I don't know if there are really 8, there may be 12. There may be a different set of skills for a cardiothoracic surgeon and for a general pediatrician. What I'm willing to bet is that most of these things are going to be on the list of every practitioner in some form or another. So one of the things that interests me in the conversation is, are these things you've experienced? Are there things that are missing from this list? Would you reformulate these in some way to make them more clear? So I'm hoping that other people will take up the task in a kind of critical mode, investigate this, and then work with it. Let me just explain what each of these means, because the meaning may not be self-evident from just reading it. The little things that are big are all the things that we should have learned from our mother. When you enter the clinic, you open the door to the examining room, you smile, you introduce yourself if they don't know you, you shake hands, you sit down, you make yourself comfortable, you keep appropriate eye contact. If the patient has friends or relatives, you introduce yourselves to them and you try to understand why they're there. If you have learners behind you, you introduce them. Everybody is introduced so that there is a sense of decorum and proper respect for this being a kind of encounter in which we're going to treat each other well. Take time and listen. The interesting thing here is that time turns out not to be clock time. It doesn't turn out to be the number of minutes you spend with a patient. It turns out to be the qualitative measure of, did you make contact? Because the perception of time is all about the quality of the interaction. At least in most cases it is. And listen. We heard a great deal about listening. Listening with the third ear, one clinician called it. Listening for the emotional valences in their responses or in the telling of their symptoms. Listening for the places in which they pause or stutter or find difficulty finding the right word. Thinking that these are places you might need to go back to and look into more carefully. Be present and open. Well, of course, you're there in the room. Everybody's present. But real presence is a decision you make. We all make decisions. Are we really going to be here? Are we just going to be physically here? And so this is what they meant. Giving someone your undivided attention, what I hope I'm getting from you now, right? This is the idea. The focus is on you. The Buddhists have a wonderful way of talking about this that I really like. Say, be here now. Be somewhere else later. And be open. That is, a sense of openness with regard to your being there, that you're not there with such a tight agenda. Find something to like or to love. Jerome Grubman, who wrote this wonderful book called How Doctors Think, has an episode that he describes that perfectly exemplifies this. He describes a period in his residency in which he said, this middle-aged woman's complaints sounded like fingernails on a blackboard to me. And I became so irritated in hearing her recitation of complaints. He said, I did all the right things, I ordered all the right tests, but I disliked this woman. I didn't like being in the room with her. And so I settled prematurely on a kind of diagnosis, he now says, that was not good care. Because I couldn't find something about her that I really was attached to in one way or another. Well, he sent her out with antacids. It turns out that she had a dissecting aortic aneurysm and died 2 weeks later. He said, we probably couldn't have prevented that. On the other hand, there is a sense in which there's a payoff to trying to figure out something about every patient that you find, if not lovable or likable, at least interesting. And the clinicians we interviewed said, it doesn't have to be something big, you know? It can be just something small. Just something small that's kind of memorable and that you sort of are attached to about that person. Remove barriers, easy enough, all kinds of barriers. Physical barriers, cultural barriers. Patients, it turns out, are exquisitely sensitive to this, about what are the levels, height of sitting levels, but the question about a barrier. Difference in height can be a barrier. A desk can certainly be a barrier. An electronic medical record can be a barrier, all right? So removing as many of those as you can, let the patient explain. Here the idea is that every patient comes in and has a narrative about their illness. And you have to hear enough of this. This is what these clinicians were saying. You have to hear enough of this that the patient feels like they've communicated the real sense about why they're there. So the studies would indicate that clinicians interrupt patients in the recitation of symptoms at what point? Anybody read this study? How soon do clinicians interrupt patients in the recitation of their symptoms? Yeah, about 12 seconds, that's right. Okay. Share authority, simple enough. Clinicians talked about this in terms of the way in which you would try to endorse when you could all the things the patient may be doing to help themselves, as well as sharing the decision process about how we're going to proceed. And be committed and trustworthy. Committed and trustworthy, or being committed to the relationship, being loyal. One pulmonologist said, I always tell patients, I may send you off to see another doctor, to see a specialist, to get a second opinion, but you're always going to come back to me. And we're going to talk about what you learned and figure out how to go forward. Okay. Where were these skills learned? And we had 3 responses to this question. Some people had, in their experience in their residency or medical school, what they call excellent models, wonderful clinical mentors. Many others had what they called negative mentors, right? Something they had seen and they said, gosh, I don't know how I'm going to do this when I'm out in practice, but it won't be like that. And more of them than either of the first 2 entries said, I really learned this from my patients. I figured out what helps them come back, what drives them away, what creates trust, and what doesn't. So my patients have been my most important teachers. Now, a standard objection we always get to this is, okay, I've got 12 minutes for the clinic visit, and now you've given me 8 more things to do. No, right. These are things you have to do anyway, so it's a question of how you do them. What is the style and tone of engagement? So it's not an extra checklist, right? It's rather the characteristic of doing things which really have to be done to begin with, for the most part. Okay, let me tell you a little bit about the patient study, which was a bit different. 55 interviews with 58 patients, because in some cases we interviewed elderly couples who were under the care of a single geriatrician, and we interviewed them together. We asked 12 of the clinicians from the previous study, give us some patients to talk to. Give us some patients who are reflective and who can speak about the character of the relationship. And you can see the spread of illnesses. We interviewed 14 hospice patients because we wanted that sample as well. And you can see the breakdown in age, education, race. It's a little bit more highly educated sample than one might run across in the general population, and I think this is because these people had time to talk, but also they were more articulate and reflective. And the interview guide was a bit different. So you're beginning with trying to place the relationship in the history of an illness or a series of illness episodes. So tell us the story of your illness, and then tell us about the time when you knew that Dr. X could help you. And then tell us about particular times that real care and concern was shown for you, and describing your relationship in general. So here, instead of this list which says, you want to have a good relationship, here are the things you need to do, people talked about the stories of their illnesses and their relationships, and so these are our categorizations, the investigators' categorizations. Vulnerability and responsiveness, we decided, were the 2 most important features from the patient's perspective of this interaction, and so we concocted what we call the structure and rhythm of doubled agency. I'm not sure you can read this in the back, but if you begin with this idea that every patient is vulnerable in some way, and I've had people say, well, you know, when I'm just going in for my annual physical or I'm going to have my lipid profile checked on, I don't feel very vulnerable. And I would say, yeah, that may be true, but let me tell you about when I was going in for my kind of annual lipid profile, and I thought I was in great shape. This was just something I was doing, because I had a little extra time that day, right? And I'm walking back to the examining room, and my primary care clinician happens to be standing at one of the desks in the hall and watches me walk in. And, you know, very friendly kind of opening, and she said, well, the first thing we have to do is figure out why you're dragging your left foot. My point being that anytime you put yourself under the gaze of expertise, whether you know it at the time or not, you have a potential vulnerability. So I began to recognize that I should stop taking anything for granted. Thankfully, the left foot drag was not anything special, but I hope it serves the point in saying there is an inherent vulnerability or being a patient. And this kind of definition we put in the upper left is supposed to get at that to some extent. Responsiveness to the vulnerability, the creation of double agency. This is necessary because if I'm going to see a clinician, I've got either issues, problems, worries, or plans that I myself cannot effectuate. So I need help, by definition. So I have to join my agency with that of somebody who knows better than I do. But that creates a risk as well as a capacity, because in that relationship I may be stigmatized, labeled, I may have my values disregarded, I may be unable to pay for the care. A whole number of things can go wrong in this process. So it's potentially extraordinarily important and powerful in terms of enhancing my capacity, but also inherently risky. Something I think we should never forget. Now, this is a little wooden, but in the interactive parts of this, there will also need to be a responsiveness on the part of the patient and a vulnerability on the part of the clinician, which we can talk about later. But this is just the beginning of the dynamic of interaction that you begin with. That's the idea here. If you look at the rhythm from the patient's point of view, I think it might look something like this. When I go in, my body, myself, really is in limbo. I'm in a liminal state. Either because I've got this chronic pain in my side or a nagging cough, or because I just think I'm in for a routine lipid profile. But, you know, I have to get the expert to tell me through examination what it might be. And that diagnosis, if it works, tells me about my past, okay, how to interpret my pain in my side or my nagging cough in the present, and then the prognosis projects me into the future, okay, in this interaction. And then if I'm lucky, I get a therapy that works and my life gets kind of rebalanced and I go back to who I ordinarily think that I am most of the time. But with chronic illness, people go through this over and over and over. And you may go through this with different illness episodes throughout one's life. So we're saying that this is kind of the basic rhythm of the way things happen. Okay, trying to put these studies together. Wounded humanity is Ed Pellegrino's phrase, and I think it's wonderful because it says, you know, I can't send in my broken arm. I have to come in with it, right? And it's me that's busted. It's not just my arm. The clinician's job, fundamentally, is opening, holding, and closing the space in which a relationship with therapeutic potential can happen. So the rituals of entry and exit turn out to be quite important, how you open and close, and what happens in the middle, right? So one way to think about this is to think that the healing skills, whatever they are, my 8 or some other larger list, are ways of creating and sustaining this therapeutic space. And they determine whether the double agency, this joining of forces, is going to have therapeutic value or not. The other thing I want to mention here is that patients over and over, when we interviewed them, said, you know, the whole environment really matters. It matters how people answer the phone when we're making an appointment. It matters how the nurse treats us when we're getting weighed and having our blood pressure checked. Every part of this is potentially therapeutic or working against therapeutics. And a lot of the clinicians said, you know, I train my receptionists to answer the phone in a certain kind of way because I want every patient to know from the beginning, this is a place where we're here to help you. And on the negative side, one woman said to us, you know, I've never been able to get over the fact that when I go in for my chemotherapy, the receptionist has long, dirty fingernails. Well, it may not seem terribly important, but maybe it is, because that sends a message somehow. Okay, a little bit more about specific traits that were mentioned by patients. Caring, empathy, and compassion, these are kind of synonyms in our taxonomy, was the most listed. Calmness surprised me a little, but maybe it shouldn't. Calmness, given the contagion of emotions. One woman said, if the doctor is fidgety, I'm going to be fidgety. Honesty and trustworthiness and access and advocacy. One of the things patients mentioned a lot, they would say with great pride, I've got my doctor's cell phone number. So then we would always ask, and how often do you use it? And most of them said, no, never used it, just got it, you know, right? It's a symbol of access. So just a flavor of the interviews. One patient said, you think from the first time she talks to you that she cares, and here's the payoff. So I can say things to her I wouldn't tell to other doctors. Okay, things you already know, things that inhibit therapeutic interaction. Perceiving that one is just an object or number. Perceiving that the practitioner is so rushed they don't really have time for you. The practitioner seems inundated. We heard an awful lot about the electronic medical record. So one of the things to talk about is how do you mitigate against that and the fact that it's required. I don't know whether you're on the EMR, but we are, and it's a big deal. So something to talk about perhaps. Okay. How would this change medical ethics? And I'll go through these a little more quickly. The moral life is something that goes on continually, meaning the moral features of the relationship, you know, constitute 99% of medical ethics, nursing ethics, all of healthcare ethics. That's where the action is. We spend so much time focused on the big decisions, life and death. But this is neglected and incredibly important. And the principles, which we all have learned and which are exceedingly important, we found didn't come up all that often. And we began to think about them as assumptions that you would have in a relationship, that if they weren't there, they would be problematic. Kind of like the guardrails, right? Or the boundary markers. But when they start coming up, you know either there's a big decision coming up or the relationship is in some difficulty. So another way to say this, principles and virtues. Relational ethics is as important as decisional ethics. Or our anesthesiologist who said, who you are is as important as what you know. Now, any guesses about who said this? What matters most in the moral life is not adherence to moral rules, but having a reliable character, a good moral sense, and an appropriate emotional responsiveness. Any guesses? Jim Childress. Okay, another way to think about this is that we're trying to shift from a kind of ethic that focuses on physicians and providers in terms of their understanding of situations to patients and their understanding. I call this a Copernican shift because it's a question about what's in the center, what revolves around what, right? The difference between the Ptolemaic and the Copernican world, pretty revolutionary. Okay, now I'll just show these without comment because these are, if we were going to take this really seriously, these are things we might put in a medical ethics oath. Okay, these are just the publications. And these are my wonderful friends, co-investigators, and the people who helped us, the people who gave us money, and my two brilliant medical students who helped us do this research. So anyway, I went a little over, but not too much. Stephanie, it's all you.
Before we begin, I'd really like to thank Dr. Churchill so much for being here today and sharing your time and insight with us. Your research on the art of healing is really inspiring and certainly challenges me to aspire to a higher standard as a future clinician. So in reading Dr. Churchill's recent book, Healers, I was reminded of the morning before my white coat ceremony. Our last orientation activity before the big event was a session on the art of healing. Initially, we listened to various seasoned doctors talk about their experiences as healers. And I'm sure there were some less sentimental students in the audience who really would have just rather gotten lunch. But for me, it was a pretty awesome experience to be on the brink of this massive, life-changing endeavor and to hear stories from the other side. At the end of the session, our professors had each of us write down 1 or 2 statements about the healers we hoped to become. They looked, to be honest, quite a lot like those things that you added to the code of medical ethics. And then we stood one by one to read our statements aloud. It was very personal and moving, and one of my classmates actually had the foresight to capture the moment, compiling our statements in an online document. I hadn't revisited this Healers Art session in a while, but after reading Dr. Churchill's work, I looked back. A few things strike me now about our statements. One is that we definitely knew how to talk the talk about being excellent healers. Our statements were filled with hopes for compassion, integrity, and courage. We promised patience and empathy. We vowed never to lose sight of our patients' wholeness. And then, at some point in the subsequent weeks, our idealism was dealt a heavy blow. It came with the first standardized patient encounter. I have no idea what my patient's hypothetical complaint was, but I do know that taking the first history, I sounded like some kind of weird robot. The sequence of questions made little sense. There were long, uncomfortable pauses. And the main redeeming quality of the whole experience was that I was not alone. Somehow, being placed in front of a standardized patient strips most, if not all, medical students of all previously intact social skills. Now, I can assure you that our interviewing skills have improved since that time, but the important thing to remember is that while our conceptual framework for being healers was already there, we had a very long way to go before being able to execute it. Looking back, I think what was most absent from our Healers Art session was any practical knowledge about how to put these lofty ideas into action. UVA faculty do a very good job about teaching first-year students interview etiquette, from handshakes to eye contact to open-ended questions to being at the same eye level as your patient. But until we hit the wards, our opportunities to practice these skills are inherently limited. I know that third year will be a steep learning curve, and that it will be a time when many of my classmates and I establish habits which may shape our patient relationships for years to come. These habits, good and bad, will be hard to shake. Before coming to medical school, I worked for 3 years at my college writing center, and by the end of my time there, sessions I had with students followed a very standard mold. I would introduce myself. I would ask if they had been to the writing center before. I would preview the process and let them know that generally we liked to have students read their work aloud as part of the editing process. Then, before we began, I would try to establish why they were there to see us. Did they have any specific concerns or things they wanted us to address? Then we would dive in and begin the editing process. Finally, before sending them on their way, I would check in with these students to see how they felt about the revised version of their work. I say this not to emphasize the details of my tutoring approach, but rather to say that it was extremely consistent and beyond that, I was quite fond of my entrenched ways. If my past is any indication of my future, I know I will establish equally set patterns in my approach to healing. Hopefully, the wisdom and example of faculty here at UVA will help make those patterns the best they can be. As first-year medical students, we come in with many of the character traits that physicians need. The admissions committee screens pretty thoroughly to try to ensure this. But merely knowing the general theory and being good people will not make us exceptional clinicians. As Dr. Churchill has eloquently described, extraordinary healers rely on many specific habits and rituals to do their jobs well. And the first steps toward making the rest of us equally extraordinary is to help share their insights. Thank you so much.
We'll let both of them get settled at the desk, and then we have, thank you both, we have a very generous amount of time to open the conversation to all of you here in the room. You bring a lot of different perspectives, so there's a rich diversity of thought and preparation here, and I think with this amount of time, the discussion will go to some very interesting places. There are 2 mics here. We'll bring them to you so that your comments easily go on the video recording. And I would ask you also to please identify yourself briefly before you ask your question or make your comment. And who would like to start? Please identify.
I'm Margaret Mormon from the Department of Religious Studies and latterly at the Center for Biomedical Ethics and Humanities. And appreciate very much both of you. This has been a wonderful session. And a question I have actually for both of you is about the teaching of this. How you think these sorts of skills are best taught, best learned, and along with that, how does one credential the teachers or screen those who are teaching in such a way? Not necessarily to weed out the negative mentors, they can be very helpful, but to have a way to help students recognize that that's a negative mentor. You know what I mean. Anyway, just to reflect on the teaching of this.
Well, that's a great question. Thank you, Margaret. I think the most successful effort we have had at Vanderbilt when something like this, we took residents who were circulating through one of our 6 intensive care units, and we said, would you be interested in learning how to talk to a family in terms of giving the diagnosis and talking to them, you know, for the first time about the ways in which your family member is doing. And we asked for volunteers. We got several people. We created 2 scenarios. One was an African-American family and the other was a Caucasian or white family. And they had roles. They were scripted as actors on these roles with all kinds of the family dynamics that we would all recognize. Anger, people who don't necessarily get along well with each other, questions about who's in charge, people who are partially stricken with grief, some of whom had rather be somewhere else. Okay, and we said, here's the diagnosis and here's what you can tell them about the course of stay in the ICU. So go in and tell them about it and try to make this a good interaction. And we videotaped them and then we showed it to them later. And they thought it was profoundly helpful in terms of them being able to notice all kinds of things, like the fact that they had sat a long way away from the table, or that they had paid no attention to the wife when she started to cry during the interaction and she was largely ignored, or any number of things. Or the question about, did I find out what the family's perception of this is and their understanding about the possible implications of the amount of trauma that's going on. All of these kinds of interesting things. That, to me, has been our most successful venture into this territory to date. The other little venture I would talk about is that we have a little time in the core clerkships for ethics. I do the one on surgery with one of my surgery colleagues, and we talk about informed consent. And then we send people out to observe informed consents. They see a lot of informed consents. They sometimes participate in them as well. And say, give us a good example and a bad example. And then that becomes the basis of a discussion in terms of what was good about it, what didn't go well about it. And of course, an informed consent discussion is one of the most frequent occasions on which you have to try to establish all of these kind of potentially therapeutic interactions and get a job done as well. So those are the two things I think that have been reasonably successful for us. But I think it's an ongoing challenge to try to figure out how to do this, and especially as, if you're like us, you know, the time for teaching is diminishing. Everybody's on the clock, everybody's on the efficiency clock in terms of clinical income, you know, throughput, all of those forces which militate against the reflective kind of time that you actually need to make this work. So I worry, this is too long-winded, but I worry that in some cases the occasion for doing this in a routine kind of learning environment may not be as present as they were in the past.
I guess from my perspective, one of the things that we do as students is we do have these standardized patient interactions, and I know one of the things that they did in the past was have videotape of our interaction with the patient. And they still do videotape it, but we don't have set times in our curriculum where we are forced to watch these incredibly uncomfortable interactions. So I think bringing that back in, or even if you are a medical student going in and taking the effort to see yourself and see what worked and what didn't, that would be one of the incredibly helpful ways of incorporating that.
Other questions? Mm-hmm.
Thank you, Stephanie, and thank you, Dr. Churchill, for being here. My name is Sylvia Kaufman. I'm a first-year medical student, and as a first year, I don't have extensive personal experience with this, but I've observed and heard from a number of care providers that frustration can develop when patients, especially over the course of time, repeatedly show or fail to address health concerns that could be addressed, namely tobacco and obesity. And some care providers have expressed the frustration that they can't get patients to change. And I'm wondering, particularly for Dr. Churchill, if any of the physicians that you interviewed in your research expressed strategies to channel that frustration into possibly behavior change, but ultimately to healing.
I think most of the time what we heard is, here's how I could continue to relate to this person without being judgmental in relation to their inability or refusal to change a behavior that I thought was really important for their health. So it was the question about what's the quality of the ongoing interaction. But we had some incredible stories about people making threats to patients that they thought worked, many they thought didn't. You know, times they, you know, one guy said, I knew I could make this work, so I took this guy by my arm out to the reception desk and said, take him off the rolls. I'm not going to see him anymore. And the guy went into such shock, right, that, of course, you got compliance. Now, this is not a strategy one would ever recommend, but it was a way of saying that every patient is different, and he knew this patient well enough to know that this had a pretty good chance of paying off But as a general strategy, of course, this is a disaster. So I think it was more around this kind of question about the relationship was strong enough that you could take a few risks occasionally. Because you knew that even though the patient would be angry with you for this, they would probably stay with you, or that you could repair that enough that something could work beneficially in the end. But see, this is the interesting thing. It's not like you learn these 8 skills and then you got it. Everybody will have a different style for doing this. Some of us are enormously funny, and that can be a great skill in relating to people. Some of us are just a little more attentive. We can notice things much easier than others, and so that can be helpful. So developing the style that's really you, puts you into that, I think is one of the keys to this. So how do you adapt this into the things that you bring, into your skill set, your interest, your abilities?
Hi, I'm Danny Becker. I'm a healer in development. I think this certainly falls under the category of lifelong learning. You have good days and bad days trying to help patients. As far as how to teach it, I'm involved in a project with a couple other medical schools that involves simulating these conversations so you can actually go into a virtual world and talk to a family or a patient or another healthcare professional and get feedback such as, I noticed when you mentioned the scan result that you looked at the floor, and that's kind of immediate. So I think there are some technologies that will help you learn how to do it, and even see what happens if I say something really dumb on purpose and see what kind of reaction that gets. So we're thinking about how to teach it, because in the old days it was see one, do one, teach one, and that was neither safe nor effective.
Yes. Thank you for that. It's interesting how easily people can get into role plays if they really want to. Some people will resist it, but it can be very effective. I think that's right. Thank you.
Okay. I have a question. I'm Emily Drake. I'm on faculty at the School of Nursing. Thank you, Stephanie, and thank you, Dr. Churchill. I really enjoyed the 8 habits of highly effective clinicians. And my question is, did you interview any nurses, or how do you see this applying to nursing clinicians?
We didn't interview any nurses, and here's a bias of mine. I think nurses are ahead of the game on this. Honestly, and it's reflected in the medical ethic, in the ethics code that you have, and the way just the phrasing of it shows that there's a different kind of point of view here. So that's a part of it. A part of it is, I work in a medical school and I have to relate to doctors, which I really love. I consider myself lucky in that way. But actually my primary care physician is a family nurse practitioner. And I realized after I did this study that I picked her because she has these qualities.
Thank you.
Thank you both. I appreciate your presentation. Lynn Noland, School of Nursing and Division of Nephrology. And I'd like to ask you about a little different realm, and that is teaching rounds and case review. And it seems to me that it's extraordinarily dehumanizing at that point, because some of the time, in fact, I believe most of the time, when you're talking in the abstract, you get gender, age, and ethnicity, and that's about it. Do you have some recommendations as to how we might modify or change the teaching realms, the teaching aspects of healthcare for physicians and nurses?
Not having experienced rounds like
Oh, you
that.
have middle rounds.
Yeah, I'm not sure but
Yeah.
I'll see something.
I think that's tough because there's an agenda on rounds, obviously. Very powerful agenda moving through. I did see one of the clinicians we interviewed on rounds function this way. And this was with a fresh student. He said, I want you to go in and talk to Mrs. Jones and find out what matters to her. And the student came out with, the typical history review of systems, blah, 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 blah. He said, no. He said, we don't know who she is. I want you to go find out who she is and what matters to her. So the student goes back in. And he comes back out and he says, the most important thing in her life is her grandchildren. He said, great, that's what I wanted you to learn. Now, let's talk about the way that would influence the care she gets. But, that's an expensive educational venture too, right? Yeah. So the truth is, I don't know. Maybe other people know how you can, or maybe we shouldn't try. Maybe this is a venue which you say, this just has another agenda, and we're going to have to find another venue for the kind of things that we're concerned about. I don't know.
Vanessa Oakes, Department of Religious Studies, but right now I speak as a consumer of medicine and as a patient. Sometimes I think that patients know which doctors are really good clinicians and which ones have weak healing skills. What are some good ways, strategies for patients to teach their doctors how to be better healers? I remember last time a doctor was looking at his computer. I wanted to shout out, yo, look at me. It struck me that might not be effective. Do you have some techniques that we who are patients can use?
One time I was interviewing this woman and I said, how would you in general describe your relationship with your clinician? She would say, it's a great relationship with his left arm. And I said, what? She said, well, he's always turned to the side and he's typing into the record. So this is how I feel like I'm interacting. A lot of people are concerned about this. Some of the things that clinicians have said to me in terms of ways to overcome this is they'll say, okay, now I want to be sure I get this right, so I'm going to turn away and type this into the record, and I'm going to read it to you. And you can tell me if I got this properly. So maybe there's a way in which a patient could say, I wonder what you're typing into the record, or would you please tell me how you're, describing what you think I have and what should be done. And I think most clinicians would take pretty easily to that. But techniques that would mitigate the absence of attention to the patient are really, who knew? But they turned out to be a big thing. You knew, right? But maybe there are ways that suggestions can be put forward in, a not so threatening way.
We have one more right here.
Okay, why don't we do?
Can we close one? Just quickly, Dr. Churchill, thank you for your presentation. To the idea of what can we do, I think the onus has to fall on us about the question about our rounds. How do we make this more personal? How do we get to the 8 lists? When we're precepting, we have to ask the question, where are you in an emotional relationship with that patient? How much trust have you built up? Do you have permission to go there? What are they afraid? If we don't have that language as mentors, by the way, I'm Dr. Sean Reed, I'm one of the film medicine faculty, but we have to model that. We have to bring that to these dialogues, whether it be on the busy hospital rounds or whether it be outpatient. Time is an issue in all those places, but that is what's essential, and we have to model that.
Thank you.
And I'm sorry, but time is an issue at this moment. We hope that we've given you lots to think about and to start the Medical Center our year with. But a big thanks to Larry Churchill and Stephanie Kaufman.